gonna record. Okay, so this is my first case. I'll kind of cut to the chase here. This is the area of abnormality. What do you guys think?
Is it a urethral diverticulum?
Yes, yeah, good. So there's like a cystic fluid-filled structure wrapping around this female urethra here. In this case, it actually has contrast going into it, layering posteriorly. So the urethral diverticulum is usually from blocked suburethral glands, and it can form like a sort of curved shape or horseshoe shape around the urethra. And one of the things that they want to know is where the neck is coming from, because they will go transvaginally and marsupialize or like resect this diverticulum, but they also want to sclerose off the neck. So we have somewhat of a clue here that the neck is in this area. But if you can't tell where the neck is, sometimes MRI can help, or fluoro can help. So in this case, we did a fluoro and we did a VCUG. So voiding cystourethrogram, more common for pediatric patients. We filled the bladder, removed the Foley, and then had the patient void. So this is the 4 centimeter long female urethra. And now we can see the diverticulum filling, and we can see this small little neck coming off the right side here. So that sometimes can help us when we do a VCUG show exactly where the neck is. So then that can guide our urologist to go and resect this. And then sometimes we do a post-op VCUG as well to make sure that the diverticulum has resolved. So I'll just zoom in a little bit more to.
It's a nice VCUG.
What'd you say?
It's a nice VCUG.
Thank you. I didn't do it. My colleague Linton did it, but yeah, it's a beautiful one. She actually managed to void while we were watching, and so I can see the tick there. Okay, I'm going to pause the recording just to make sure I don't. Okay, these next two I'm going to show are PET MRIs. We've started doing PET MRI, which is very exciting. So this was a patient who had a Whipple. You can see that they've got this atrophic remnant pancreas, their jejunal loop here. So on the staging CT, their CA19-9 was rising. We didn't feel that suspicious that there was anything at the pancreatico-jejunostomy. We don't see dilation of the duct. We see a little bit of air maybe in the duct there. But there was suspicion here in the liver. There were some hypodense lesions, so we were concerned for metastatic disease. We thought this was the only site of disease, and the radiation oncologists were thinking about doing targeted radiation therapy to this part of the liver. They wanted to know if there was any extrahepatic disease. So we did a PET MRI. This is the fused images from the PET MRI. So first, you can see in the liver, there are multiple lesions, more so. So for example, this one we did not see on the CT, and there were more extensive lesions than we could see on the CT. We also saw that there was this node. There was also recurrence at the pancreatico-jejunostomy that we missed on the CT. And I think there was also a node in the chest. So this was a case where the PET MRI kind of really showed us nicely a lot more metastatic disease. And I would say, like, for example, if I saw a node even this small on CT, there's no way I would have been able to say that's definitely involved, or this little recurrence that wasn't blocking the duct yet. So this was a really nice example of PET MRI showing us a lot more disease. Any questions? Are you guys doing PET MR?
We are.
Cool.
In the near term.
So I guess I was just asking my colleague Melina, she said we're mostly using them for GYN, but also all of our dotatate scans are now being done with PET MR fusion. And then our axamin prostates are also being done with PET MR. And then I guess hopefully soon we'll get PSMA.
We do pancreas with PET MR.
Oh, all of your pancreas.
The treatment, the post-treatment ones.
Yeah. Wow. Yeah. Like for example, this case. Cool. In regardless of their CN99 rising, like all of them you do with PETMR.
Was that a
Was that by
question? Sorry.
request of was that because of radiology, or was that request by the providers?
Is that a question for me or Aarti?
Yeah, Nelly, I think we're asking one, do you do all of your pancreatic follow-ups with PETMR? And then I think Flo asked if you guys decided that, or the providers asked for that, or.
Oh, I think we have a protocol for it. And I think like that's being also actively studied as a research question. So that's why we do them.
Cool. Okay, I'm going to pull up my next one and I'll reshare. Oh, wait. Let me stop. Okay, this was a patient who had endometrial cancer. They'd had a nodal dissection of retroperitoneal nodes. This was a follow-up CT. And they've had a hysterectomy and oophorectomies. And their vaginal cuff here looks a little bit full. But we looked and saw, like, a year ago, it also looked full. So weren't completely sure if this was normal fullness of the vaginal cuff or if this was recurrence. What would you guys call it?
The left side looks a little bit more suspicious, maybe.
Yeah, and it was
Because of
excellent
the
reference.
heterogeneous attenuation.
Exactly. And it looks so heterogeneous and a little bit bigger than 1 year ago. So we weren't sure. So we ended up doing the PET-MR. And now you can clearly see that both areas of the vaginal cuff are really, really hot. So this was definite recurrence at the vaginal cuff. And actually the patient was having vaginal bleeding, and on exam, they thought there was something suspicious there. So that was also another clinical clue. But anyway, this was another one where PETMR just definitely like clinches it. No questions here. Okay, this is not a PETMR. This is a patient with abdominal pain. Kind of similar to something Nelly showed last week. What do you guys think?
The vessels are going through it. I guess I definitely put lymphoma in there in addition to some kind of.
Is it some kind of gist?
Metastasis or just definitely.
Yeah, so I would definitely say mesenteric mass, our two main differentials are going to be GIST and lymphoma. I like the vessels going through for lymphoma. It does look very mass-like. One other clue here is that this bowel loop is circumferentially thickened and seems to be involved with the same process. And I would say you don't usually see that with GIST. GIST is usually arising from the submucosa of one piece of bowel and growing out. So this is much more consistent with a lymphoma. So anyway, we biopsied this, and this was a B-cell lymphoma. They put the patient on chemo, and this is 4 weeks later. So kind of just to show you, like we can still see that thickened bowel loop and then the mass, but it's much more necrotic, looks much less enhancing. So this is the post-chemo effect, that the mass it's undergoing treatment, but it also has perforated. You can actually see that there's fluid, rib enhancing fluid in the pelvis, and also a fluid collection over here in the right paracolic gutter. So,
Didn't remain contained then, did it? It's like basically.
Yeah, and I think
perforated.
exactly. I think probably just from the tumor lysis, the wall kind of broke down as well. The patient's actually clinically doing great, so we're just treating conservatively. They did put a drain in one of these, but Even though it looks gnarlier, I think it's probably actually responding nicely to the chemo. Okay, and then I just have one more. This is a follow-up to one that Victoria showed last week. She showed a lesion on MR that was at the anterior superior aspect of the bladder. On MR, it was T1 bright, T2 dark, and it ended up being resected, and it was a urachal cyst. And this is kind of a nice companion where we see this like super dense, like calcified thing at the front of the bladder. It could just be a stone stuck up there, but it could also be like stone or debris within a urachal cyst. This patient also happens to have all of this pleural thickening, came in with shortness of breath. This was their first presentation, and unfortunately had this huge breast mass that has now metastasized to the pleura and also to the opposite lung.
So we did 2 MRIs back to back. This is the second one. The first one's basically the same. There's only one wrinkle of difference with the second one, but this was being admitted due to, I guess, suspected gallstone pancreatitis in a middle-aged female. And there was a incidental finding basically here. So here's the non-con, it's a fat sat T1, a T1. It's like a Dixon fat imaging, and here's out of phase.
Does it have some dropout in it?
FNH?
Probably.
It's like that lobulated thing near the caudate with some
Yeah,
dropout.
the lobulated thing sort of in the
Looks like an FNH.
gastric region here. And now that here's the post contrast. This is pre-post. There's actually a lesion here. I'm not sure if there's 3 or maybe there's just 2. I don't know.
So I think Kadar keeps saying FNH.
Yeah. So
This looks like an Eovist scan, does it?
here too. So you had a hard time seeing it maybe on the pre-contrast T1 and T2s, and then arterial phase contrast like FNH does, bright contrast. This one here is pretty typical. This one here is pretty typical. In the later phase, maybe that one has a central scar. This one is the atypical one, which is I had to look at images of FNH that are exophytic before I felt confident that that's for sure what it was. The first MRI, they recommended getting Eovist. This is actually the second MRI with Eovist. And so I'll show the delayed, well, here's the T2s. So you didn't really get the T2s. Actually, for FNH, sometimes these are relatively T2 bright. And I find FNH as often a little bit more ISO. But here's actually that's an early late phase. I think there might be a later, an even later one. Let me see if I can find it. Yeah, there is a late hepatobiliary phase, but look how these things take up the contrast.
It's gorgeous. And also it's a nice example of how the central scar doesn't take it up because it doesn't have the OATP receptors.
Right.
But
no
we shouldn't be alarmed. Yeah.
That one's got a central scar. This one maybe not so much central scar. This one kind of has a weird looking irregular central scar if you want. But it's very exophytic. It kind of connects to the liver, I think over here, but. So we call these FNH and are good with observing them, which I think there was one follow-up, which is, there's no time has passed. I didn't really.
It's also a really nice example of that it can be a little bright on the T2.
Yeah. Yeah, I mean, like I said, I like to see it a little bit more ISO on the T2, but these are a little bit brighter, and I guess that's okay. They all look the same. That's helpful that they're sort of multiple. You can see maybe T2 bright in the center of this one a little bit if that's the scar, and then maybe the other one's got a little T2 bright scar there.
Yeah, they're so pretty.
I'm glad you like it.
Yeah, that Eovist is beautiful. Okay, Flo, you're up.
Awesome. Okay. So let's see if I can do this better this time. Share screen. Let's go with portion of the screen. Okay, perfect. So this is funny because this is more of a lung case, but it just became an interesting thing for me. So maybe this may not be the best case, but just scrolling through so everyone can get a quick overview and form some ideas of what may be happening. This is a trauma case, if that helps. I'll just scroll right back up.
There's some pneumatoceles here, but in the setting of trauma, you might think maybe those are related to trauma, although they don't, they look a little weird for trauma pneumatoceles.
Right?
Yeah, I'm thinking
Wait,
maybe.
are they on any inhalational drugs?
Right, and that was part of our original differential, right? Like these ground glass opacities, you're thinking, maybe there's some kind of inhalational injury, maybe there's something else happening. What we found really fascinating though, after looking for a quick radiographic search, these are pulmonary lacerations. So these compression injuries happen. So this is all pulmonary hemorrhage that happens in the lungs, and you get these compression shear injuries that can happen, especially in certain types of lacerations that push against the spine. And you get these lacerations that fill with fluid, and all of this is hemorrhage and contusion. So yeah, that was a fun case.
That is really cool.
And then I can even pull up the radiographics article, but I don't know if I have it here. Do I have it here? Oh, this is the other one. Oh no, I don't want to reveal the answer. Okay. And I'll just pull it up really quickly. And you might want to pause it for a second. Okay. So this person, history is a recent cyst-gastrostomy. And I'll say this is the non-contrast, this is the arterial, and this is delayed, and this is a delayed coronal. I don't know if anyone sees anything suspicious. It may not be immediately obvious, but I guess I'm gonna
So
give the hint away.
I'll just say what oh no, go ahead, Steve.
I didn't know where to look. I'm like, I thought I saw something that looked like it was.
So I see the distended stomach with the NG tube in it, and then I see the cyst-gastrostomy tube going towards the pancreas with contrast going in it. I don't see much of a fluid collection, so it looks like whatever pseudocyst or walled-off necrosis is decompressed.
Mm-hmm. I think I'll give a hint is this is, a bleed study. So there's a non-arterial and delayed, and there's notably something we do not give during a GI bleed study.
Oh, so that oral contrast in the stomach was not oral contrast. That is
Exactly.
extravasated.
Goodness.
Yes.
Whoa, and did you find the vessel?
We did not, but it's just fascinating to see. Later there was an IR study that was done to try to embolize
A vascular injury resulting from the
cyst-gastrostomy. Yep.
gastrostomy procedure. Then.
And it was found to be the splenic artery that was causing this.
Yeah.
Wow,
Right,
I've definitely had my gastroenterologist ask me like preemptively, like, is the stomach next to the collection? Are they effaced to each other? And are there any varices or other major vessels there? But I've never had the splenic artery in the way. Sometimes all those varices, because the pancreatitis took out the splenic vein, there'll be this gastric varices, and that will be a contraindication. But yeah, wow. And that's actually a good pitfall one, because it was so much contrast. You just like almost didn't see that wasn't there on the non-con. Like you just presume it's oral.
Right,
contrast.
exactly.
I don't know, but you guys,
scared me.
we hardly use oral contrast at all anymore. I know that Perry Pickard and others have gone on their soapbox and said, it's useful for X, Y, and Z, but we tend not to use it routinely.
Yeah, we don't use it routinely. We have different opinions in our group for oncology follow-up, but generally these days we don't use it. We definitely don't use it in the ER. We use it sometimes for post-op, for like leak after post-op, or to make sure that the contrast gets through if we think that there's a post-op ileus versus obstruction. We'll do a long delay with oral contrast and make sure it gets to the colon.
But obviously, anytime you're doing like a CTA and looking for bleeding, you wouldn't want to have any positive GI contrast on board, right?
Yes, no. Oh, Flo, I see you've got we can't hear you though.
There's your
Oh
traumatic.
yeah, sorry. Sorry, I was just going to share that this was the radiographics article that had the pulmonary lacerations that looked exactly like our case. So anyway, that was that from before. Sorry, I skipped over this in between doing the other case. That was it. That was all for me.
That's great, Flo. Thank you. And we will sign off early. And we are not going to have conference in the next 2 weeks. So have a wonderful holiday, everyone. Take
Thanks,
care.
everyone.
Ooh,
Happy holidays.
enjoy your time off, everybody. Hopefully you get some.